Good evening, everyone. I'm Dr. Hita Patel from IAP Digital Media Team. I'll be host for the today's webinar on central sensitization, understanding and managing the persistent pain with a resource person, Dr. Subhangi Gaikwad. It is organized by IAP Women's Health Delhi State. The Indian Association of Physiotherapists is the oldest and largest association representing the physiotherapists in India since 1955. The IAP digital media team consists of a group of physios who handles the Zoom platform, webinar live streaming, and IAP profile on social media platform Facebook, Instagram, Twitter, LinkedIn, and YouTube. Follow the IAP profile on the social media to receive the notifications for our events such as webinar, workshops, CMEs, conference, health checkup, blood donation drive, and to know about the recent updates on physiotherapy. Subscribe to IAP YouTube channel for notifications of our live webinars. In playlist section of this channel, webinars are segregated in various folders on a topic like orthopedics, neurology, sports and fitness, pediatric, cardiopulmonary, women's health, research, and cancer rehab for easy access. The social media link will be shared in the chat shortly. Over to Jasmine, ma'am.
Thank you, Heta. Good evening, everyone. Welcome to this beautiful Sunday evening. I am happy to have Dr. Shubhangi Gaikwad with us. Myself, Dr. Jasmine, representing Delhi IAPWC State, and also one of the moderators of this webinar. So today we will be talking about the central sensitization concept, understanding and managing persistent pain. This concept will be delivered by a very unique person, that is Dr. Shubhangi Gaikwad. Madam has an experience of more than 15 years in clinical and rehabilitation. She's currently based in Dubai and is heading as consultant physiotherapist in Saudi German Hospital, Dubai. She's been there as an in charge of the rehab department since 2014. Madam is competent in improving and diversifying the services, upgrading the patient experience, and expanding various organizations within the rehab scale. She has led the expansion of physiotherapy departments, not even in India, but in Dubai also. So thank you, Dr. Shubhangi, for connecting with us and accepting the invite of IAP. IAP Women's Health is thankful to you for having this unique concept being spread to the physiotherapists in and around the world. Over to you.
Thank you. Thank you so much, Dr. Jasmine. And it's my pleasure to be in this platform and share some of my knowledge with all the colleagues and our physio mates. So shall we start the presentation?
The stage is all yours, ma'am.
Okay. I think the screen, you can see the screen now? Hello?
I'm yet to see yours.
Okay. I think Nidhi ma'am has to do from her end, or
Now it's visible. Please put it in the slideshow mode.
yeah. All right. Central sensitization, it's understanding and managing persistent pain. So this is a very interesting topic, and let's begin and dive into it. So my first question to all of us is, it's a very common clinical scenario. Why do some patients continue to experience pain long after the tissue has healed? Anyone wants to say anything about this scenario if they have ever faced this kind of situation in the clinic? Right. So most of us, some or other days, we feel we get the patient in the clinic who says that my pain is still the same. So what is wrong in our treatment plan? We are doing everything for the patient, manual therapy, electrotherapy. We are doing multimodal treatment plan to the patient, and all the scans are good, all the blood reports are okay, the assessment is showing that we are in a right track, but why the patient is still complaining of the same pain, right? And it's not happening only with you, it's happening with all of us. So let's just be clear about it and just relax. And, we need to understand what is the main factor behind these type of patient who are never recovering and who is always having the pain. So my next question to all of you is, what is central sensitization? And more important, why every physio should understand it? Because central sensitization is not just like neuroscience buzzword. It's like clinical lens which will help us to guide our patient in a better way by ourselves understanding their pain in a deeper manner and then helping them out in our framework. So the learning objective behind this webinar is very clear. From like my aim is to make central sensitization understanding in a very simpler way so that we can recognize patient pattern which are suggestive of central sensitization, plus how we can apply practical simple clinical tools and treatment to help these type of patients. So what is central sensitization? Central sensitization is a condition in which the central nervous system, which is made up of brain and the spinal cord, become hypersensitive to the input. It means that the pain can continue even when the initial injury has been healed, even when the tissue has healed, but still the patient is having this sensation of pain. They are experiencing the pain. That state is called central sensitization when the nervous system, the central nervous system is involved in this process. So what is the analogy behind this? So it's like the body alarm system is stuck in a high alert mode. So the alarm is the pain. So the even when the tissue is healed, the inflammation has been resolved, but the body is still sensing and experiencing the pain and giving a high mode alert to the person that he or she is still having this pain. So, what are the neurophysiological changes in the central sensitization? This is something we really need to understand. And once we know that, it will be easier for us to manage these type of pain. Okay, so we all know that pain gate pathway is made up of three major components: nervous system, like the nerves, spinal cord, and the brain. So what happened in central sensitization? There are some kind of neurophysiological changes in these three components: the nerves, spinal cord, and the brain. So we're gonna learn more about it now. Neurophysiological changes happens in the glial cell, in the dorsal horn of the spinal cord, and the certain areas of the brain. In all these three components of the pain gateway pathway, there is overactivation, hypersensitivity in these areas. Okay. So let's start with the nerve cell, the glial cell, which maintain the sensitized state in this concept of central sensitization. So the glial cells are the supporting cell in the central nervous system. They are not neurons, but they play a crucial role in maintaining the health and function of the neuron. When there's a persistent pain signal like any injury or inflammation, glial cell become activated. And now this activated glial cell change their normal supportive role and start releasing pro-inflammatory substances like cytokinin, chemokinins, and prostaglandin. And because of these activated, like continuous activation of the glial cell, it enhances the neuron excitability, which causes sensitized dorsal horn of the spinal cord, and that amplifies the pain signal into the higher system. Then comes the spinal cord, the increased responsiveness of neuron in the dorsal horn of the spinal cord. So we all know dorsal horn neurons are key relay point where sensory signals from peripheral nerve first enter the spinal cord before being sent to the brain, right? Normally, these neurons respond appropriately to noxious, painful stimulus. But what happened in central sensitization, these neurons shows increased excitability. So even non-painful stimuli can be perceived as painful, which is called as allodynia. Or a painful stimuli can cause exaggerated pain sensation, which is termed as hyperalgesia, right? Then third part is the brain itself. And brain itself play a major role in how the pain is perceived, interpreted, and emotionally processed in our body. So brain play a major role in interpretation, perception, and processing it emotionally and bringing it out as an experience in any person. So in central sensitization, basically three part of the brain get overactivated, which are the anterior cingulate cortex, insula, and the prefrontal cortex. So let's see how does anterior cingulate cortex affect the pain experience in our body. So the ACC is involved in the emotional and motivational aspect of the pain. Basically, how much pain bothers you or how unpleasant it feels to you. So it is the work of ACC. When there's overactivation of the ACC, it increases the emotional distress related to the pain, making pain feel worse even if the actual sensory input hasn't changed. It also play a role in attention to pain and how we respond to it. So the emotional and motivational aspect of the pain is controlled by the ACC. And in case of central sensitization, when it is hyperactive, it makes us more aware and like the experience of the pain get exaggerated. Second part is the insula, which is a part of cerebral cortex. So the insula processes interoceptive signals, that is information about internal state of the body, including the pain intensity and the location. It integrates sensory and emotional information, contributing to the subjective experience of the pain. When there is overactivation in insula, it amplifies the awareness and unpleasantness of the pain. So we have seen a lot of patients coming to us like they constantly feel pain in certain areas, and even though they say that the VAS is in the lower side, but the experience of pain is too high. So this is coming from this part of the brain. Then comes the prefrontal cortex. Prefrontal cortex is crucial for cognitive aspect of the pain, including evaluation, decision making, and regulating emotional responses about the pain. When overactive, the PFC may heighten pain perception by influencing attention and emotional reaction, sometimes leading to pain catastrophizing, excessive worrying about the pain. And it goes to certain level, like patients start feeling that pain is like a threat for them. And also this area makes them, like they tend to make them attention seeker, like because there is increased perception and they want everyone attention towards them. Secondly, PFC also modulate descending pathways, so can either amplify or inhibit the pain signal. So in case of chronic pain, they inhibit the efferent fibers, which is trying to like close the pain pathway. So, overactivation of brain area lead to increased perception about the pain, heightened interpretation about certain kind of pain stimuli, and emotional distressing. So, a brain itself play a major role for the central sensitization because it is increasing our perception, our interpretation, and how emotionally we are experiencing and expressing the pain. So the question is why brain overactivation, why the brain overactivation happen, right? So in chronic pain or in central sensitization, because of persistent pain signal, it leads to plastic changes in the brain, that is neuroplasticity. And these neuroplastic changes increases activity in emotional and cognitive center, which reinforce the pain experience. Like we have seen in PFC and insula, all these areas get hyperactive, and that's why we feel that's why the patient feel too much pain even when the tissue has been healed or there is no inflammation. So essentially, brain learns to expect and amplify pain, contributing to ongoing suffering even if the injury has been healed. So even when the injury has healed, brain will continuously signal the person that you still have pain and you're not in a safe zone, you are in a threat mode, right? So this flow chart is about how our acute pain get converted into chronic pain and then leads to central sensitization. So when uh, when there's an acute pain, we know how our pain gateway pathway works, right? So, but what happened when there's a persistent pain signal because of the chronic pain? Beyond the normal healing process, dorsal horn get hyperactive, which increases the firing of the neurons. This leads to dysfunctional pain gate mechanism. So there will be less inhibition and more facilitation about the pain experiences. That continuous dysfunctional pain gate mechanism leads to neuroplasticity, which is long-term changes in the nervous system structure and also the function, which leads to brain overactivation, which we have seen in these three part of the brain, right? Which process the brain pain sensation to our body, and this leads to chronic pain. Pain becomes like a disease itself, and all these changes for a longer period of time when all the central nervous system has been affected in the nerve level, in the spinal cord, or in the brain, that leads to central sensitization, which is increased responsiveness of the whole CNS. So now the question is the clinical assessment. How do we assess and how do we differentiate these patients from our normal patient? Because there are certain objectives and subjective clues which you can grab and try to tweak a little bit in your treatment plan and help these patients recover in a better and a smoother way. So what are the subjective clues? The subjective clues, first of all, we all know any pain which is staying for more than 3 months is considered as a chronic pain. And uh, chronic pain, if it is staying for more than 3 months, is what is doing in our body is slowly and gradually it is affecting our nervous system, and it is getting converted into a disease kind of pain, like a central sensitization. These patients not only have pain in a particular area where they had injury or there is some malfunction, but they will have these deep, dull, ache kind of pain in white in a larger part of the body, like, and also they can have a pain not only in the neck, but if a cervical LGA patient is coming to you having neck pain initially, but it's staying for more than 3 months, gradually what will happen? They will have pain in the shoulder, in the back, even in the knees. So they will complain pain in various part of the body. Secondly, non-mechanical pain not consistent with load movement. That means these patients will have pain even when they are resting, even they are not increasing the intensity of their exercises, even they are doing limited range of motion exercises. All these symptoms are showing and giving a clue that they are moving towards central sensitization. And these patients always show some association with emotional distress, sleep issue, fatigue, and this is relating to their pain experience. And as I have told already, the pain migrates without pattern. So there's no pattern. The neck pain patient can tell you that I have a pain in the calf also today. So they don't follow a pattern, or they don't follow localized pain area. Then comes the objective clues. So there are three major clues which you can look for if you are trying to help any chronic pain patient, like allodynia. They will feel pain even with the light touch. Hyperalgesia, strong pain with very mild touch or pressure. Like when you are just palpating and trying to assess them, they will just jump and scream out of pain. So this is indicating that they are suffering from hyperalgesia, and it can be the case of central sensitization. Plus generalized tenderness, they will always have pain beyond one areas. Okay. So what are the screening tools? Key question about pain, pet, fatigue, light touch. All these are the screening tools. When we gather all this information, and then we have to understand and think maybe this is indicating towards the central sensitization. Also, what you can do is you can have, when like one patient is coming and he's in the last three session, he has told you that he has pain in different area. Then what tool you can use is like body mapping. Make a body map and give it to him, and every time the patient comes to you, tell him to mark that place where he's having pain, and you'll find out that maybe in sixth session, he will be marking the different areas of the body having the pain. So this is a clear-cut example of having central sensitization. Inconsistency in pain with light touch, range of motion, as suggested, is suggested in central sensitization. So there will always be an inconsistency in how they are, not only the area, but also how they are explaining about the pain. It's like they sometimes they are really vague about how they are experiencing pain. So these are the indication which you can rule out to have the patient under central sensitization. So here are some questions which I usually use in my clinic to categorize chronic and central sensitization patients. So the first question is, do you have widespread body pain? Secondly, do you feel more tired than usual even after resting? So even during the resting phase, they feel pain. This is one of the classical symptom of these central sensitized patients. They have a disturbed sleep, so it is very important for us to understand their sleep pattern, what time they sleep, how many hours of sleep they are getting, and is their sleep is like it's light or they sleep deep. It's very important for us to understand this. Fourth question is, do you feel more sensitive to bright light and bright lights or loud sound? Because the whole central nervous system is has become so sensitive that even the lights and the heavy sounds, louder sound can make them feel discomfort, can increase or initiate the experience of pain they are having. Fifth question is your pain not clearly linked to any injury? Uh, we usually get some patient in the clinic, like they just have pain. They don't have any history how the pain has started, but they will tell you like, I had pain in my back and now I have pain in my neck, but some days I get pain in my shoulder also. So there is no link. There is no past injury, and even their scan, their MRI, X-rays are completely fine. But you can when you will assess them, you will find there will be increased spasm in throughout the body, or there can be some stiffness in one part of the body. So these are the connecting links which you can join and figure it out. Like, is this patient is really a central sensitized patient? Sixth question is, does your pain seems to spread to other areas over time? So they will always have pain radiating to different areas. Uh, the next question is like, does gentle touch feel more uncomfortable or painful than expected? Another question, do you have difficulty concentrating or feel mentally foggy? So this, if they say yes, this say that this indicates that this patient also have some kind of emotional attribute towards his pain. So his emotion, his processing system has something, or he is stressed. Something is environmental or psychological is also activating the pain mechanism in his body. Another thing is about the mood. Is your pain of mood? Is your mood affected by your pain? Or vice versa. It can happen like sometime a patient who are stressed, who are in a sad mood, their pain also increases. And it can also happen counter effect also, like if they have too much of pain, their mood can go into like sadness, and they will tell you, yeah, I have stopped going out. There is a social withdrawal also. And the last question is, does stress or emotion make your pain feel worse? So, as I explained, stress can also be one of the factor affecting the experience of pain of a person, because all these are interrelated. Our psychological, our environmental factor does affect how we are perceiving our pain. Other than that, it's very important to rule out the red flags like fracture, infection, and tumor. It's not like every patient who is not recovering is the candidate of chronic pain or central sensitization. It's very important. It's our duty to understand and rule out the red flags like fracture, infection, and tumor. So the next question, when we know that, yeah, this patient is indicating towards central sensitization, what is our rule and how we can help? So the protocol or the framework you are making for managing this patient can should actually include not only the normal physiotherapy session, but also small addition of different modalities, which we have learned throughout our syllabus also in the college and while growing as a professional, right? So first of all, yes, multimodal rehab plan for these type of patient, for the central sensitized patient, chronic patient, it's best to use a combination therapy, including manual therapy, TENS, dry needling, whatever skill you have learned and you think that it is indicated for this particular patient, you should apply, but always apply and combine therapy for this patient. Secondly, is the graded exposure. That means we should bring on exercise therapy or manual therapy in a very slow, gradual way, because the tolerance of these patients are very low. So if you introduce something very intense in one session only, they will end up having soreness. They will not show up for the next visit, because for them, pain is like a threat. Pain is they are so fearful of the pain that if in a session a physiotherapist like going very intense and increasing their pain, it's very much likely that they will not show up in the next session, or they will change the therapist. So these are all the practical scene which I have seen and experienced. So it's always better to go in a very gradual manner for these type of patients. Education, that's the most important part when it comes to a chronic patient. Even if you are not 100% sure that why that this patient is central sensitized, or it has central sensitization going on his body, it is very important to explain why the pain is not going. Okay, so when we educate them, when we give them education about pain neuroscience, it reduces their fear and threat about perceiving the pain. Because for them, pain is like a threat. It's not been a 1 month or 2 months. They had been into this pain for a very long time, more than 3 months. For some, it's for years. So, and they have never got the education why they are still having pain. uh, like even when they are taking medicine, they are going for different physiotherapy session, chiropractor and everything, but nothing is helping out because the problem is not only mechanical, or it's not only in the musculoskeletal system, it is affecting their brain processing system. So when you will help them by educating them, it might help them to, change their perception about the pain. And that's why the importance of education in these type of patients is very, very important. Then the next tool which we have is regulation or regulate. What does it mean? We have to work on regulating the nervous system of the patient, and it can happen through some relaxation technique, breath work, body and mind techniques, where we will just calm the patient down. And once they are calm, they can process the pain in a better way, because a calm mind reduces the activity in the brain areas, which is causing this continuous signaling to the brain that there is still pain existing in your body. Okay. And then addressing their thoughts and emotion. Maybe at certain point we are not competent enough to help them because it is related to thoughts and emotion, then we can suggest them to go for a cognitive behavioral therapy, which will help them to change their emotion and thought process about the pain. And it is really helpful because, as I have been mentioning, that they take the pain as that the pain gonna live with them forever. It's their belief system. So it's very important to work on their belief and their fears, and through the cognitive behavioral therapy principles, and definitely individualized treatment plan, because for every patient you have to pick something or other to help them in a better way. Plus, I always believe in empowering your patient by giving them some self-management tools, like even, like if a chronic OA arthritic patient is coming to you and you just tell them that, whenever you have pain, you just do this isometric exercises and you will feel change in your pain. It will reduce, and give them a modification in isometric. Give them like do this stat in a dynamic position, change the position, like do it in sitting, do it in standing, do it faster, do it slower. So these are the small modification you can give them for self management. What will happen is, because they know they have this tool, and their mind will start working in a positive reinforcement manner. And when they will do these isometric exercises, when the pain is aggravating, they will feel a little bit relaxed, and this gives a boost to them that yes, my pain can be managed. So what is the mechanism behind all these treatment plan which we have? So the tools like exercise therapy, manual therapy, what it does, it actually work on the mechanism of releasing the anti-inflammatory substances which are present in our body, and it also increases the endorphin and serotonin, which reduces the neuroinflammation. Secondly, when we incorporate mind and body practices, it actually reduces the stress response, thereby lowering the glial cell driven neuroinflammation. So it will reduce the neuroinflammation by stimulating the good hormones in our body. When we choose manual therapy, TENS, draining our the physiotherapy tools like these, it alter pain signaling in the spinal cord and help to dampen the central sensitization, because it will inhibit the pain sensation in the patient. So what are question you can use while you are educating your patient about central sensitization? So here are some question I have selected for all of you, which can help the patient in a better way, and we will not only educate them, we will understand the patient, because like I always tell to my team that if you really want to manage the pain of a patient, you should know how to manage the patient. once you know about your patient in a better way, you can help them in a very simple and easy way. So try to understand your patient first, and then it will be very easier and simpler to help them with their pain. So let's check these questions. The first question you can ask your patient is, what do you understand about your pain so far? So this will give you the insight about their belief, this misconception and emotional tone. I'll give you one example of my patient. So I had one patient, she had chronic arthritis of the knee. And when I started asking her some question, and then she told me that, I asked her, what have you seen in your pain? Like, what do you think about your pain? So she gave me a very funny answer. It was funny to me, but maybe that's her belief system. She told me that, Shubhangi, whenever there's a new moon or a full moon, my pain goes up. So that's her belief system. And you won't believe that she used to schedule her appointments during the new moon or full moon. So that's her belief system. And once I know that she believes in this new moon and this thing, so I changed my protocol, and I changed how I'm talking to her. And this helps us not only to, educate them, but also how we modify our treatment plan. So these type of misconceptions comes up to you, what your patient is actually thinking about their pain when you ask these questions. Second question is, has your pain ever felt out of proportion to the injury or hard to explain? This guides the patient to recognize feature of central sensitization. So when you ask this question, like, do you feel that you are experiencing pain out of proportion? Like it's been a long term. We have seen your reports. It's all clear. In your physical assessment, also, I'm just telling you, like like the spasm has reduced, the range of motion is better, you're moving better, you're performing better. But do you think there's you're feeling the pain out of proportion? And they will admit yes, and then they will start thinking why it is happening with me. And once you introduce this concept of central sensitization and how our body works with these type of chronic pain, it will be easier for the patient to accept it. And then you will see a major change in how they are perceiving their pain. All right. So the next question is, what makes your pain worse or better apart from movement? So other than the movement oriented question, this will bring about the awareness about how the patient is interpreting or experiencing the pain when there is a change or trigger in the emotional status of the patient. Environmental issues are there, or stress related triggers. Like environmental means, there are certain patients who comes and say, uh, as soon as my boss talks to me, my I start having the neck pain, or I start getting migraine. So these are environmental factors. Emotional, like when they have some relationship issue, or they feel distressed because of any reason, it always show up in how they are perceiving the pain. And this condition, these factor actually worsen the pain. And once they tell you all these stories and all this relationship between their emotional, environmental, and stress related triggers, you can help them better. Like if you can't help them, you can actually send them to psychologist, CBT therapist, and all of that. So it will make your life easier as a clinician, as a physiotherapist. The next question is, would you be open to learning how your nervous system might be sensitized and how we can calm it down? So, what this question help you with, like it's actually creating a space and a rapport between you and your patient, and you're also trying to seek their permission that, like I would love to help you out, but you also have to understand that there are certain things which you need to accept. So once they are in the accepting mode and once they give you this permission, it will be more easier for you to educate them and to empower them about the chronic pain or central sensitization. Right. And another thing, um, uh, don't tell a patient that this is my personal experience. Don't tell a patient that your pain is psychosomatic because um, they've been hearing this since a very long time because they keep going to the doctor again and again for the prescription of the medicine. And doctor usually tell them, like after certain appointment and after certain prescription that, man, your pain is not in your back or your knee, your pain is in your head. So in that situation, patient really feel humiliated, annoyed, and they feel that these healthcare professionals are not willing to help me. They are just giving me painkillers and blaming it to my stress or that my pain is psychosomatic. And another thing is the stress, yes. Not only psychosomatic, don't always relate their pain directly to the stress because nowadays it is we all have stress, right? So patients start comparing themselves that if if everyone having the same stress, they are not having the pain, but I'm why me? So they don't want to accept it that the stress is the triggering factor in their experience of pain. So when you think and when you feel like, this is the right time that I can speak about it, then slowly and gradually, with indirectly, you can bring this out, but not in the very first or second visit. That's why it's very important as a physio to have a good rapport with the patient. And as I said, it is very important to, kind of understanding your patient. I'm not talking about their uh, um, the disease process, the pathology. No, just try to understand the patient as a human first. Yes, it is very difficult sometimes when we have, like very busy schedule, very busy OPD, back-to-back patient. So it's sometimes it's difficult to talk so much, but we do get more time with patient that we all know, right? Every patient comes to us at least 5 to 10 times. And in that 30 to 40-minute session, they are on the passive modality some of the time, and most of the time they are interacting directly with us. So when you have this 15-20 minutes also with you, try to talk to them, try to understand what is their belief system, what they are experiencing about their pain. So once you understand the human behind your patient, then it will be easier for you to help them out and bring a small tweaks in the protocol. It will make a big difference. As we have already talked, so these are some movement and calming strategies which you can always incorporate in your treatment plan, like a graded movement exposure, like slowly, gradually build up the exercise plan and manual therapy. Breathing exercises, it activates the parasympathetic nervous system and calm the stress response. So we all have learned you don't have to do any intense breath work, even if you are giving them a very relaxed, deep breathing exercises every session or at least at home. It will be easier for them to come out of this. Mindfulness and meditation, yeah, that this will also help to relax them. Then body scanning and progressive muscle relaxation. Give them some self relaxation technique which they can help when they are in a stressed or painful situation. So, what are the key points through this webinar I wanted to convey to all of you that the pain can persist from our nervous system. sensitization. So it's very important as a therapist, we have to understand it's not always the tissue which has been inflamed or injured. The pain can be coming from the central nervous system or the nervous system. And also validate the patient's experience. The pain is real, right? Don't dismiss their experience or what they are telling you about their pain. Try to understand in a deeper way, educate them, give them gentle movement, breath work, mindfulness practice. But the basic concept when you have a chronic or the central sensitized patient is you have to calm them down, increase their confidence, and then gradually load them with the your exercises or whatever treatment protocols you have. So I'm done. This is all about central sensitization, and if there is any question, I would love to answer that.
Thank you, Dr. Subhagi. It was a wonderful session. I think I myself, after having such a good experience, got to know what's inside the pain. So, just wanted to know from your experience, this concept that you have clinically applied, you have clinically observed, how old chronic patients have you treated so far with this?
Sorry, I didn't get you. How?
So, all I'm saying is that with this concept, when you realize this concept and you understood the concept of pain, how old chronic patients, the chronicity, how old chronicity have you dealt with in your experience?
How? How I like? I didn't get you.
How old chronic patients, like how
How
old
old
is
chronic
the patient?
patient? Okay.
Yeah.
So I have seen patient who has been suffering, who have been into this chronic pain since between 3 to 6 months. Because when they are in constant physiotherapy session for more than 2 months, they are actually frustrated. And from there itself, it started building up in their head. Like there are some changes in their central nervous system. Um, like how they are processing and perceiving that pain. So between 3 to 6 months, I will say.
And how important you feel, Dr. Shubhangi, communication about and the knowledge of pain to a patient and for a patient is important in healing.
It is very, very important. Like I have also mentioned in the webinar itself, that it is very important to talk to the patient and to educate them about what is going on in the body. But because as a patient, what they are seeing is, I had a cut or I have an injury here and I am experiencing pain. That's all about the patient is no, okay. But when they go to doctor, they hardly give them time. But when they come to physio, we have enough time to talk to them and develop the rapport and understand them and make them clear about why they have been having this pain for so long time.
All right, thank you. So we have a question here that how much duration is required for planning of the treatment and how much time will it take for the healing?
For the patient, for chronic patient.
Yes, for chronic patients.
So for chronic patient, uh, like if you talk in terms of duration of session, I think even 30-minute session is good enough. What I do is I give only 30 minutes to the patient. And in that 30 minutes, I do 20 minutes of manual therapy. And during that manual therapy, when patient is very much engaged with me, I talk to them, I counsel them and I educate them because in a running OPD, it's very difficult for you to take out only time for counseling. So practically 30-minute session twice a week. That's what my protocol is, even for chronic patients.
All right, thank you so much. And I have one serious question to ask. There are times when the pain pathway becomes accommodated or gets adapted too early. So how do you tend to break that adaptation
So for
in a
that, if
chronic
it,
patient?
you're talking about acute pain,
In a chronic patient.
the best way technically as a physiotherapist is to keep changing your protocol, like do a combination therapy, and the combination therapy, not only everything in one go, but give it in an interval of time. Like a patient, I know that he's gonna come to me for 3 weeks, so I will start with normal physiotherapy, educate them. Then second, like in the second week, I introduce like dry needling or cupping, and in the third session we gradually move to more exercise oriented protocol. So tweaking and changing and modifying the treatment protocol is the best option.
All right, thank you. So we have another very interesting question that, ma'am, what changes will you prescribe to one patient who complains of increase in pain intensity during full moon and half moon day? The therapist is curious because old patients are very adamant and they don't accept advices normally.
Uh, See, I have given you the example of my own patient who has pain in the full moon. So it's basically the counseling, because you cannot bring about the changes in your treatment protocol. It's all about, reviving their belief and thought process. And for that full moon and new moon, whatever their belief system, give them some tools. Like for me, I told that patient, for that full moon, when you start having pain, you have to do rapid isometrics. And I added sciatica stretches on that, and it worked. It worked. And that's how you tweak your patient. The basic principle of all the treatment plan will stay the same. But that's why when you understand your patient and you understand your subject and your treatment plan, you can bring about any changes and they will feel the difference because it always works.
That's a perfect answer. I hope that solves the question. Another question that was even I was curious to ask is, nowadays multimodal, I would say multimodal modality therapy is in time, right? It's trending rather, I would say, where alternative practices and complementary practices are also taking place along with physiotherapy. So how do you plan a multimodal therapy for such patients?
You means
What do you,
machine-based modalities.
right, I would say, because since understanding by your knowledge is what I also feel is international practice is all about manual therapy, right? And engaging the patient in right practices. But since the concept of multimodal therapy has also been come up, where we also talk about biopsychosocial model too.
Yeah.
So, how do you see the
I,
compliance of such
it's
models?
very, there are two things, okay? It is very important to understand the what your patient want and need. The need is something we can take care, but what your patient want is something which you get from your patient. So I be here because in UAE we kind of pamper the patient. So it's very important to understand what they want, not only what they need. So there are certain category of patient who wants only manual therapy, and there are certain category of patient who come just to rest with the machines. So it is very subjective according to the person. But as a therapist, I combine everything, and this is our part to educate them that only machine will not help you and only manual therapy will not help you. Like for 40 minutes or 30 minutes, I will not be giving you manual therapy. It will actually increase your pain by increasing the micro traumas in your muscles. So this is your how you are positioning yourself. So the very first session when you are interacting with the patient is very, very crucial, where you have to be soft, but you have to be in that position to command and make sure that you are gaining the confidence of the patient.
All right. So another interesting question that has come up is, how do you incorporate graded exposure or pacing strategies to help patients with chronic pain, improving function without triggering the flare up.
Um, when you talk about graded, so when you will see these chronic pain patient, their mobility is good, okay, most of them, but they have this pain symptom all the time. And when you incorporate graded or paced program by increasing their confidence and showing them little changes what they are getting, that definitely helps. So it's very important to communicate and show them even the smallest changes which you see as a professional in the patient. Like you can always tell them, your spasm is in the lower side today. Your scapula look more balanced and stabilized. So these are the small prompts you should always, because what we do is, we as a clinician, sometimes we just look into the into the bigger picture, and we avoid telling them the small changes which we are getting in every consecutive session. So it's very important to tell them about that and give a paced exercise program.
I think that makes a lot of sense because it's always said that focus of what you have gained rather than highlighting
Yeah.
the positives behind it,
And
right?
these central sensitized patient or chronic patient, they will always, you will see majority of them are little sad and depressed. So if,
Yes,
even a small positive changes in their body, it brings a lot of difference in their thought process itself.
true. Another question that we have got is that what is the rationale behind mindfulness technique in curing pain,
In chronic pain.
in
So
curing the pain?
mindfulness actually works on your belief system and your thought processing. When you educate the patient through mindful practice, they will see the positive changes rather than the negativity of the condition. So that's how mindfulness works. And when you show them the changes, like in the nervous system, let's forget, like if you have a back pain patient and he or she has a severe pain, and also when you assess the SLR is very limited. So when you start giving small sciatica nerve mobility exercises, in the next session, maybe the pain level is same, but the range has increased. So that's also a kind of mindfulness you are showing to them, like you have to be mindful about what we are gaining, not about what we are still on the same level.
Also, I believe I'll add to your point. One another scientific rationale is that mindfulness techniques they release the endorphins too. So
Yeah.
it
Yes.
enhances the
Good.
circulation of dopamine, so that also adds to potency. Right. So we had a lot of curious questions today, and I'm sure it will be worth, uh, I would say, an information to deliver to all the audience that we had over here. So thank you so much, Dr. Subhanji, for your wonderful time and knowledge that you have shared for this, I would say, pain that is actually a pain for physios and becomes a nightmare to treat with, right? So, on behalf of IAP, I would like to thank Dr. Sanjeev, our national head IAPWC, Dr. Ruchi Vashne, our North Zonal head, Dr. VP Kurana, our president, Delhi IAP, Dr. Pooja Sethi, and our Delhi State IAPWC head, Dr. Nidhi Kalrak, for giving us this opportunity to share this wonderful experience with all the budding physios over here. Also, I would like to thank all the Delhi IAPWC team for their wholehearted support and contribution so that we can bring a better change in their lives. And on behalf of IAP and IAPWC, thank you so much, Dr. Shumani, for giving your wonderful
Thank
time
you
and
so
knowledge
much,
to us.
Dr. Yasmin. It's been my pleasure to share some of my knowledge with all of you, and thank you so much.
Thank you. Thank you. Thank you, everyone.